All right, it is 12:01, so I'm going to go ahead and get started. Thanks everybody for being here. My name is Sally Saffy. I'm the Director of Graduate Studies in the PFRH department, and I'll be facilitating the session. So we have four master's students in the Department of Population, Family, and Reproductive Health who will be presenting on their final master's essay presentations today. I do want to make a quick note that if you are looking for the session, there's two simultaneous sessions happening right now. If you're looking for the session with Amy, Daisy, Jordanos, or Emily, please go to the other Zoom link. But thanks everybody for being here. We'll have 4 presentations today. The presentations will be about 10 minutes long, and then we'll have about 5 minutes for Q&A after each session. I just want to remind everybody to please make sure that you're on mute during the presentation, but of course you can come off of mute and ask a question or put it in the chat after each presentation. So we're going to go ahead and get started. Our first presentation is from Nicole Brennick. Nicole has a Bachelor's of Science in Biochemistry from the University of Washington. She's here in the MS-PhD program in the Child and Adolescent Health area of interest. So Nicole, I'll turn it over to you.
All right, great. All right, can everybody see my slides?
Yep, looks good.
Perfect. All right. So today I'm going to be presenting on my research report, which is titled A Prospective Birth Cohort Study on Early Childhood Comorbidities Among Subgroups Defined by Gestational Age. As Sally said, my area of interest is in child and adolescent health. My preceptor was Dr. Brandon Smith, and my reader was Dr. Xiaobin Wang. So for kind of an organization of how we're going to go through this project today, I'm going to start with an introduction, go over why this work is important, methods, which I'll go over data cleaning and descriptive statistics, and results, what did we learn, and then lastly, a discussion and conclusion where we'll go over implications, limitations, and next steps. So starting with the introduction, why is it important to study healthcare utilization? So preterm births are high in the US compared to other high-income countries. Currently, 1 in 10 babies are born prematurely. There are persistent disparities with Black pregnant people being more likely to deliver preterm than their white counterparts. Other risk factors to give birth prematurely include maternal age at birth, both outliers of the spectrum, both young and old, low maternal education, previous preterm births, and nulliparity, which is meaning it's the first birth for that pregnant person. Babies born preterm have worse health outcomes over the life course compared to babies born full term, including immediate comorbidities, which include respiratory or gastrointestinal difficulties, and longer-term comorbidities that include neurodevelopmental, behavioral, and learning difficulties. Families of preterm infants report higher financial and emotional burden and healthcare utilization compared to families of full-term infants. So moving on to methods, we're going to start with some study objectives. So our goals were to assess trends in ambulatory healthcare utilization by gestational age over the first 5 years of life. And we wanted to assess primary diagnoses per encounter across each year during the first 5 years of life. And before we move on, I want to take a moment to define what we mean by ambulatory in the study. Ambulatory encounters encompass both outpatient clinic and emergency department visits, and it does not include inpatient or hospital visits. So this study, we used the Boston birth cohort. So just an overview of what that means. So this actually was started by my essay reader, Dr. Xiaobin Wang, and it was developed in 1998 at the Boston Medical Center, or BMC. The goal was to explore the health disparities experienced by Black, Latina, and Indigenous pregnant people and their newborns, and preterm births are overrepresented in the sample 2 to 1. The child health study is the longitudinal version of this study where we follow participants' healthcare use and outcomes. It started in 2004 and it's still continuing to this day with an average follow-up time of 14 years. In this study, we're going to talk a lot about the ICD-9 codes, which are the International Classification of Diseases. These are billing codes that are typically used to describe the purpose of a visit. The use of ICD-9 codes ended in 2015, and our encounters in this study are from 2004 to 2015, meaning that ICD-9 codes are the most, they matter the most for us in the study. So for our data cleaning methodology, We have two main populations that we're looking at. So we have the participant level and the encounter level. So starting with the participant level, we combined the Boston birth cohort data set with the longitudinal data set that I mentioned on the last slide to create a all study participant data set. From there, we removed all participants that were not the first child enrolled in the study. And then that's when we get our final study participant data set of 3,416. So if you want to see that arrow to move over to the right side, we have those 3,416 participants, and we combine that with the number of encounters we have in that child health study data set to get a total participant encounters of 176,012 encounters. After that, I removed all the inpatient encounters and any encounters outside the study frame to get a final participant encounters data set of 88,350 encounters. So moving on to descriptive statistics, I did all the statistical cleaning and analysis in RStudio. Gestational age categories were determined by research convention defined by less than 28 weeks as extremely preterm, 28 to 31.6 weeks as very preterm, 32 to 37 weeks as moderately to late preterm, and 38 weeks and later as full term. Because the raw data only included the month and year of delivery, we determined that all participants would be given the 15th as the day of delivery per previous convention. From there, I made a birth date variable, which allowed me to create a study end date variable that added 5 years to the participant birthday. From there, I removed all encounters that happened outside the study end date for each participant. Furthermore, using the birth date variable, I created an age variable that measured age in months to allow for data frames defined by a year of life for each participant. With age and gestational age categorical variables, I made separate data frames for each year of life and each gestational age category. For example, this means I had a data frame for extremely preterm participant encounters from age 12 to 23 months. And lastly, I used the primary ICD code variables to order the codes by frequency within each of these age and gestational age specific data frame. So moving on to our results. So this is the summary of our demographics. So over all across all different subgroups, we see that the maternal education level, maternal marital status, and race are high school graduates or GED graduates. Almost the majority of pregnant people in this study are single, and most of them identify as Black or African American. In birth weight, we see that full term have the highest birth weight, which is what we'd expect. And then for each of the different preterm gestational categories, we see an increasing birth weight with increasing gestational age. And then in the last row, we see how many females we had versus males in each of the groups, where we hover around 50% in all groups, but we see an especially low percentage of female infants in the extremely preterm group. And then also, it's important to state that the study population follows the trends that we've seen in previous research, along with the characteristics of the Boston birth cohort. All right, for this slide and the one on the next, I calculated the rate of healthcare utilization by dividing the number of encounters. For this slide, outpatient clinic visits, and the next emergency department visits by the number of participants in each subgroup. Something interesting to note in this graph is we see a similar decrease in outpatient visits across all groups. Along with that, we see two groupings. So it's these two, which are extremely preterm and very preterm, and these bottom ones, which are full term and moderately late preterm, that have similar trends across the first 5 years of life. Moving on to healthcare utilization by emergency department visits. Unlike the outpatient graph on the previous slide, this graph does not have a general trend across the subgroups. One thing specifically that stood out to us when reviewing this data was that we see the 2-year-old very preterm participants overcome their extremely preterm counterparts, so this area right here. And this is something that was unexpected, and we intend to dive into this finding in future studies. This graph shows the primary reasons for each encounter by body system across each year of life in the preterm subgroup that was not further stratified. The most common reason for encounters across all 5 years lies in well child visits and health maintenance. This includes yearly physicals and vaccinations. The second, third, and fourth most common reason for encounters are growth and development, respiratory, and musculoskeletal. However, it is important to know that growth and development and musculoskeletal have quite a bit of overlap, as I define the codes that fell into each system. For the purpose of this study, growth and development codes included feeding difficulties and developmental delays, and musculoskeletal codes included unspecified problems with limbs. Furthermore, we saw the highest number of respiratory ICD-9 codes in the first year of life, which mirrors the previous literature. So moving on to our discussions and conclusions, our main takeaways are that children born preterm have more ambulatory healthcare encounters compared to children born full term. And clinical implications of this study are that it gives families of preterm infants, clinicians, and public health professionals a natural timeline for expected healthcare utilization. And our findings are consistent with prior research studies about healthcare utilization among preterm participants. However, this study provides unique insight into the healthcare utilization trends using a longitudinal prospective cohort for years 0 through 5. And then lastly, for limitations and next steps, some limitations are that this is only sampled from the Boston metropolitan area, which means our generalizability might not be as strong to generalize the findings to other areas in the United States. And then the healthcare utilization data is only from visits in the Boston Medical Center system, which means that we could be missing some data points from participants who used other healthcare systems as well. And for next steps, we're going to do some more research using healthcare utilization trends with NICU stay. For our subsequent studies, we plan on replicating the same methods from this study to stratify the data by NICU admittance and common comorbidities of prematurity. So thank you. A special thanks to Dr. Brandon Smith, Dr. Xiaobin Wang, Serena Rusk, and Dr. Kartik Mocker for help with this project. Thanks to my advisor, Carolina Cardona, for all of her support and guidance in the past 2 years, and to my family and friends for their support and for coming today. Thank you.
Thanks so much, Nicole. Great job. I will now open it up for questions. I have a few minutes for that. Feel free to just come off mute. So Flo has a question in the chat, and she wanted to ask if you would expect any interesting results specifically across different geographic regions in the US.
I mean, probably with healthcare utilization being different based on access. So in certain states, you might see that they have less access to regular healthcare visits because hospitals and clinics are much further away for them. So we probably see a much lower healthcare utilization in those groups.
Wonderful. Thank you so much. An amazing presentation as always.
Thanks, Flo.
Other questions? I had one question, maybe it's just a clarifying question for the visits. You included just like well-child routine visits in the outcome? Is there a reason that you included those? I guess I would expect that maybe you'd be looking more for like emergency visits or things that wouldn't be expected. So could you talk about that a little bit?
Yeah, definitely. So our original plan was to not include those kinds of visits. I think it was just a mix of time permitting being able to take out all those visits. And also, since those are the majority of the visits we see as primary diagnoses, it felt like it was important to share that a lot of the reasons that these individuals go to the doctor is for well-child visits.
Thanks. Last call for final question. All right, well, great job again, Nicole. Thanks a lot. We'll now go to our next presentation from Alexandra Starr. Alexandra has a Bachelor of Science and a Master of Science in Neuroscience from the University of Delaware. She's in our MHS program with an area of interest in maternal, fetal, and perinatal health. I'll turn it over to you now, Alexandra.
Thank you so much. I'm just going to get my slides pulled up. Thank you all. Can everyone see?
Yes, you do have. It looks good. Yeah.
Okay, great. Fantastic. So good afternoon, everyone. Thank you so much for being here. Today, I'm going to be sharing research from my thesis exploring how maternal immune activation during pregnancy may influence a child's neurodevelopment with a focus on what we can learn from cord blood immune biomarkers using proteomic data. To begin, we know that fetal brain development starts as early as week 3 post-conception. This is a period when organ systems undergo critical structural and functional programming. This early window is especially sensitive to inflammation and immune disruptions. Maternal immune activation can result from infections, fever, or inflammatory responses and may have lasting consequences for fetal development. Prior studies, including work from the Boston birth cohort, has linked maternal immune activation exposures like fever, flu, and antibiotic use during pregnancy to an increased risk of neurodevelopmental disorders, including attention deficit hyperactivity disorder, ADHD, and autism spectrum disorder, ASD. However, the biological mechanisms that connect maternal immune activation to these long-term outcomes remains poorly understood, and that gap is what this study aims to address. This research is important because neurodevelopmental disorders are highly prevalent. According to the CDC, about 1 in 31 children in the United States are diagnosed with ASD, and approximately 1 in 9 children ages 3 to 17 have ever received a diagnosis of ADHD. Prior research on the association between maternal immune activation and neurodevelopmental disorders has largely focused on a very limited set of immune markers, mainly cytokines. This very narrow scope has likely missed other key proteins that are involved in the association. Our study addresses this gap by using broad proteomic profiling to examine maternal, placental, and fetal immune signaling at a birth time point. By identifying novel biomarkers, this study lays the groundwork for better understanding this association and ultimately supporting early screening, intervention, and services for children and families. The overarching goal of my capstone project was to investigate the immune mechanisms that underlie the association between maternal immune activation and neurodevelopmental disorders by analyzing biomarkers from cord blood samples that may mediate the association. What I'm presenting today is only 2 objectives out of a much larger project. First, to examine associations between maternal immune activation and child neurodevelopmental outcomes, including ASD and ADHD in the whole Boston birth cohort. And second, to identify cord blood immune biomarkers associated with maternal immune activation in a smaller proteomic subset. Our study population comes from the Boston birth cohort, a long-standing and well-established prospective birth cohort based at the Boston Medical Center. It's been funded continuously by the NIH for over 20 years and currently includes about 8,700 mother-child pairs. The BBC is a predominantly urban, low-income, and racially diverse cohort, which provides a powerful foundation for studying early life exposures and child health outcomes. In this study, the primary exposure was maternal immune activation. This was defined using 2 complementary sources of data. We used maternal self-report of fever during pregnancy, which was collected through a standardized postpartum questionnaire, and we incorporated placental pathology findings, which indicated any evidence of intrauterine inflammation. These 2 indicators were combined to create a binary maternal immune activation exposure variable. The primary outcome was any neurodevelopmental disorder diagnosis collected from pediatric electronic medical records. We also conducted secondary analysis examining specific neurodevelopmental disorder subtypes, including ASD and ADHD. The comparison group for these analyses consisted of children with no documented neurodevelopmental disorders, which were labeled as neurotypical. For Objective 2, I worked with cord blood proteomic data that was collected and processed by collaborators using the Olink Explore platform. The dataset included over 730 inflammation-related proteins measured from cord plasma samples. I'm not going to go into the lab methods here, but my role focused on analyzing the protein expression dataset to identify immune patterns associated with maternal immune activation. To strengthen the validity of our findings, we adjusted for a broad range of covariates. These included key sociodemographic, biological, and behavioral factors that affected both the mother and the neonate. With that, I'm going to walk through the findings from Objective 1, which tested the association between maternal immune activation and child neurodevelopmental risk. For Objective 1, in the full cohort of nearly 3,000 mother-child dyads, using an adjusted logistic regression model, we found a statistically significant association between maternal immune activation and any neurodevelopmental diagnosis, with an adjusted odds ratio of 1.28 and a p-value of 0.021. The most robust association was observed with ADHD, where the adjusted odds ratio was 1.60 with a p-value of 0.001. This indicates an increased risk of ADHD among children prenatally exposed to maternal immune activation. In contrast, the association between maternal immune activation and ASD was not statistically significant. The confidence interval for this result was very wide, and it crossed 1, which may reflect very limited statistical power to detect a relationship here. So now that we've covered the results from Objective 1, let's turn to Objective 2, which asked, does maternal immune activation alter fetal immune signatures in cord blood? We examined 577 mother-infant pairs with available proteomic data from cord blood samples. Using multivariable linear regression, we modeled protein levels by maternal immune activation exposure status, adjusting for the key covariates I mentioned previously and plate number to account for any possible interassay variability. To manage the very large number of proteins tested in this analysis, we applied FDR correction with a significance at p less than 0.05. So what did we find? These are the results from the analysis of Objective 2. This forest plot highlights 13 proteins that were significantly associated with maternal immune activation. Several proteins were significantly upregulated in maternal immune activation exposed infants. Notably, CSF3 and IL-6 showed the largest effect sizes. Both of these are central to pro-inflammatory signaling and immune cell recruitment. These biomarkers have also been previously linked to early brain development, suggesting that they may play a key role in the biological pathway that connects maternal immune activation to neurodevelopmental risk. Conversely, we also observed a group of proteins that were significantly downregulated with maternal immune activation exposure. These biomarkers are involved in neuronal signaling and synapse formation, pointing to a possible reduction in in-uterine neurodevelopmental support among maternal immune activation exposed infants. So looking into the future, we plan to test associations between cord blood biomarkers and neurodevelopmental disorder outcomes and conduct mediation analysis to assess how these immune markers may explain how maternal immune activation contributes to neurodevelopmental risk. But before I wrap up, I think it's important for us to reflect on the strengths and limitations of this study to better contextualize our findings and shape future studies. So this study has several notable strengths. It uses data from the Boston birth cohort, which is large, prospective, and very racially diverse, and that is ideal for studying early life exposures. Furthermore, this study integrated clinical, epidemiological, and biological data, also using very objective exposure measures and adjusting for key confounders. Also, the use of proteomics enabled us to identify possible novel immune biomarkers that may inform future studies. But that said, there are several important limitations to point out. Our maternal immune activation exposure definition partially relied on maternal recall of fever, which may introduce bias into the study. However, this definition was complemented by the use of clinical data, like placental pathology, that provided evidence of any intrauterine inflammation. Residual confounding also remains a concern, particularly from any unmeasured infections or maternal stress, which may affect the measured association here. We were also limited by the smaller sample size of the proteomic subset. And the biomarker data that was captured was only captured at one time point at birth, and that potentially misses any earlier immune activity. Future studies may expand on this measure longitudinally to explore additional time points. Despite these limitations, the study provides some very important insights into how the prenatal immune environment can shape neurodevelopment. So in summary, the findings from this analysis offer important insights into the prenatal origins of neurodevelopmental disorders. First, we found that maternal immune activation was significantly associated with an increased risk of neurodevelopmental disorders, particularly ADHD, highlighting the importance of maternal inflammation as a developmental risk factor. Second, we found evidence that cord blood proteomics may offer a window into the fetal immune response. We identified several biomarkers that were altered in maternal immune activation exposed infants, suggesting their potential role in this biological pathway. These findings together support a growing body of literature linking prenatal inflammation to attention-related neurodevelopmental outcomes. They also emphasize that inflammation during pregnancy may play a compounding role in shaping child neurodevelopment, which lays the groundwork for future screening strategies and targeted interventions that are aimed at modifying inflammatory exposures during pregnancy. So thank you all. This project was made possible by a really extraordinary team of mentors, collaborators, and participants. I am very deeply grateful to Dr. Wong for her exceptional guidance, critical insight, and unwavering support throughout this project. I would also like to thank my academic advisor, Sally Safi, and the entire Boston Birth Cohort research team for their intellectual contributions and encouragement. I'm incredibly thankful to the Boston Birth Cohort families and participants whose contributions really make this work possible. Finally, I want to express my heartfelt appreciation to my peers, professors, and family. Your kindness and encouragement has really sustained me every step of the way. So thank you all for your time and attention, and I am happy to take any questions that you have.
Great job. Thanks so much. Feel free to come off of mute, raise your hand, put a question in the chat. Yeah, David, Dr. Page.
Thank you. Just two great presentations, very informative. I was curious along a couple of lines, and that is in terms of maternal gestational period birth weight considerations in this, and what follow-up in terms, and specifically whether there was follow-up regarding birth outcome. And the other issue was whether you looked at iron at all, which also has a neurodevelopmental impact as well as on myelation and a number of other issues. So thank you, and it's out of curiosity I'm asking a question.
Thank you so much. Those are really fantastic questions. Your first question dealt with preterm birth outcomes, I believe, and you asked about birth weight. I didn't specifically look at birth outcomes in regards to lower birth weights, but I did use a 37-week preterm birth category, and this wasn't necessarily in the list of covariates, but it was tested using a joint effect model. So I looked at the impact of inflammation and preterm birth, and then one or the other, and then the absence of both. And there were some very interesting findings there. A greater than additive effect of preterm birth in combination with inflammation on the outcomes tested here, specifically any neurodevelopmental disorder outcome. It's very exciting stuff. I didn't have time to address that in this presentation, but it's absolutely something that's been a huge topic of conversation in hopefully building this into a publication in the next steps. So thank you. Your second question, I believe you asked about iron. That's not something that I have read too much about, but it's something that I am very interested in now. So thank you, Dr. Page.
Thank you. It's just wonderful. Two presentations.
There's also a question in the chat from Dr. Gross, who says, very impressive work. Previous research with the BBC linked maternal diet qualities, such as the Mediterranean diet and NDD. How does maternal diet possibly mediate maternal immune activation response?
Oh, that's very interesting. That's a direction that I haven't explored in too much depth, but I did look at nativity, maternal nativity, as an option there. And I think that has also been talked about quite often in regards to diet changes among a large cohort of people. And I did find nativity-specific differences in a stratified sensitivity analysis there, specifically looking at USA-born mothers had a higher odds ratio, led to a higher odds ratio of the any NDD risk. And there were some other interesting findings there. I haven't specifically looked at diet previously, but that's a very interesting approach. And I would love to talk about that further, Dr. Gross.
All right, great. Final call. Hey, great job again. Thanks so much. We'll turn to our next presentation from Zeyu Li. Zeyu has a Bachelor of Medicine in Preventative Medicine from Fudan University, and she's in our MSPH program with a child and adolescent health area of interest. Take it away, Zeyu.
Thank you, Sally. Hello, everyone. Welcome to the third Boston Birth Cohort Studies today. And thanks for coming for my master's essay presentation. The title of my essay is Prenatal PFAS Exposures, Newborn Mitochondrial DNA Copy Number, and the Modifying Role of Maternal Folate Level. My essay reader is Dr. Shelby Wang. PFAS is a class of over 10,000 chemicals. They are extensively used in food packaging, personal care products, and cookware. And almost everyone around the world, including pregnant women, are exposed to PFAS. Moreover, PFAS can be transferred to the fetus, who is rapidly developing and particularly sensitive to environmental exposures. PFAS persist in human bodies and environment, leading to long-term exposures and chronic health effects. Prenatal PFAS exposures have been reported to be associated with adverse health outcomes across life stages, including low birth weight, cardiometabolic disease, and immunosuppression. However, the understanding of underlying mechanisms is limited. Mitochondria, commonly referred to as the energy powerhouse of the cell, plays fundamental roles in energy generation and cellular homeostasis. Mitochondrial DNA copy number is highly sensitive to environmental exposures. In adults, lower mitochondrial DNA copy number was associated with age-related health outcomes, such as all-cause mortality, cardiovascular disease, and cognitive function loss. Mitochondrial DNA copy number during the fetal period can influence the early life cell development and then may impact health throughout the life. We hypothesize that alteration in mitochondrial DNA copy number may help explain the long-term health effects of prenatal PFAS exposures. Despite our understanding of adverse health effects of PFAS, these chemicals don't degrade in environment and human bodies, which means it's unrealistic to eliminate PFAS shortly. As we know that people are already exposed to PFAS, we need to figure out other ways to mitigate their harmful effects, such as nutrition intervention. Folate is an essential B vitamin, which are critical for DNA synthesis and repair. In both animal and population studies, folate deficiency has been associated with mitochondrial DNA instability and impairment. Therefore, adequate folate may have protective effects on newborns' mitochondrial DNA copy number. In summary, in this study, I aim to investigate associations of prenatal PFAS exposures with newborn mitochondrial DNA copy number and assess maternal folate level as a modifier. The study was conducted in the Boston birth cohort, a predominantly Black and Hispanic, low-income urban prospective birth cohort. Trained staff approached any woman delivered at the Boston Medical Center 24 to 72 hours after delivery, collected informed consents, questionnaires, medical records, and biosamples. This study included 572 mother-newborn diets with both PFAS and mitochondrial DNA data. For the exposure, this study selected and measured 8 PFAS in maternal plasma samples based on a CDC standard PFAS panel for the US population biomonitoring program. These 8 PFAS are the most detected in the general population and represent typical exposures in our daily life. For the outcome, we measured mitochondrial DNA copy number in cord blood sample and measured maternal folate level in maternal plasma samples. For a statistical analysis, as the study included 8 PFAS, I investigated their effects as individual PFAS, which means I look at one single PFAS each time, and as the PFAS mixture, which means I look at all PFAS altogether, and consider that they may have some interaction because they have similar chemical structures. For individual PFAS, I conducted smoothing plots, generalized additive models, multivariate linear regressions, and for PFAS mixture, I conducted Bayesian-Canonical machine regression. I stratified the analysis by maternal plasma folate level, and the analysis were conducted in R. Let's talk about the results of the study. First, this is a table 1. We can see that 54% of the participants were non-Hispanic, and 26% of them were Hispanic. 18% of the mothers smoked before or during pregnancy, and 17% of the infants were born preterm. This figure presents the distribution of maternal plasma PFAS concentrations. The x-axis is the age PFAS. The y-axis is the median and interquartile range of PFAS concentrations. The detection frequencies are below each PFAS name. We can see that all 8 PFAS were detected in over 90% of pregnant women, and PFOS has the highest level among all the PFAS. When I examine the associations between each individual PFAS and mitochondrial DNA copy number, I observe different associations for different PFAS. Let's use PFNA and PFOS as 2 examples. In these figures, the x-axis is the level of the PFAS. The y-axis is the mitochondrial DNA copy number Z-score. The left figure is for PFNA. We can see that the PFNA was inversely associated with mitochondrial DNA copy number, but only at a higher level. The right figure is for PFOS. The PFOS is the PFAS that has the highest level among all the PFAS in the study. And interestingly, for PFOS, we found a consistent inverse association. After association for individual PFAS, this figure shows association for the mixture of 8 PFAS. I fixed all 8 PFAS out from 10th to 19th percentiles to estimate the changes in mitochondrial DNA copy number. The figure suggested the cumulative effects of 8 PFAS. In this figure, I observe an inverted U-shaped relation. In other words, positive association at lower exposure level and net inverse association at higher exposure level, which is consistent with what we found in the last slide. And an explanation for such inverted U-shaped relation is a compensatory mechanism of mitochondria with a threshold. When mitochondria was exposed to mild adverse factors, such as low-level PFAS, the mitochondrial DNA copy number may increase to accommodate the reduced functionality and rescue the cell. Once the exposure is beyond the threshold, such as high-level PFAS or PFOS in our study, mitochondria fail to repair the damage and drive the cell to an irreversible death process, leading to decreased mitochondrial DNA copy number. When we stratified analysis by maternal plasma folate level, we got this figure. The red lines represent the group with the lowest maternal folate level, quartile 1. Green line represents quartile 2 to 3, and the purple line represents quartile 4. We can see that the inverse associations was only found in newborns with low maternal folate levels. The findings suggested protective effects of adequate maternal folate level against prenatal PFAS exposures. In conclusion, the study found a consistent inverse association between PFOS and mitochondrial DNA copy number, and nonlinear association of certain PFAS and the PFAS mixture with mitochondrial DNA copy number. Adequate maternal folate level may attenuate the PFAS and mitochondrial DNA copy number associations. The study contributed mechanistic insights for health effects of prenatal PFAS exposures, and the protective effects of adequate maternal folate level may suggest novel intervention strategies. I'm also very excited to share that this work has been selected as an oral presentation at the 2025 ISES-ISEE joint meeting in Atlanta this August. Mitochondrial DNA copy number isn't the only health outcome linked to prenatal PFAS exposures. In other research I conducted within the Boston Birth Cohort during my MSPH program, I also found associations between prenatal PFAS exposures and increased risk of childhood obesity, hypertension, and cord plasma metabolomic signatures. Together, these findings form a chain of evidence showing how prenatal PFAS exposure may affect health, from altering genetic factors to disrupting metabolism, and ultimately increasing the risk of cardiometabolic disease in children and adolescents. PFAS are chemicals that everyone is exposed to every day, and we need greater attention and stronger regulation on PFAS to protect pregnant women, children, and their future generations. Finally, I want to thank everyone who has supported me over the past 2 years. I'm especially grateful to everyone at the Center on the Early Life Origins of Disease, my advisor, Dr. Xiaobing Wang, and my other research mentors, Dr. Jessie Buckley and Dr. Mingyu Zhang. I also want to express my heartfelt thanks to the Department of Population, Family, and Reproductive Health, the incredible faculty, staff, and my wonderful cohort. Thank you all for being my side throughout the journey, and I'll carry everything I've learned during my MS-PH program with me as I continue my academic path. And I'll always be a proud PopFam student. Thank you so much.
Great work, great presentation. Thanks very much. We'll now open it up for questions for Zeyu. Is there a question in the chat? Are there particular chemicals, maybe chemicals not included in this cohort study or presentation that you would recommend focusing on in future research, and why those specific chemicals?
Yeah, great questions. Yeah, so in this study, we selected and measured 8 PFAS. So in this study, we selected these 8 PFAS because they are the most detected in general population and can represent the typical exposure in our daily life. And these PFAS are also very frequently measured in other studies, but not all of them are frequently measured. For example, like ME, PFOS, ACOH, and PFDEA, these PFAS are only measured in several cohorts. But in our studies, like in this study, I only represent part of our results. In our studies, we observed some associations or even stronger associations for PFDEA and PFUNA, 2 PFAS that are less frequently measured in other studies. So I will recommend other studies to focus or try to measure those PFAS in their studies and to see if they can observe similar results. And also, as I mentioned before, the PFAS is a group of over 10,000 chemicals, but our study only covered 8 PFAS. Like even for like enhanced or some national biomonitoring program, they only cover like 10 to 12 PFAS. So it's like we already understand some harmful effects of some typical or traditional PFAS, and we try to replace them with some new types of PFAS. But our understanding for those the health effects of those PFAS are very limited, and our understanding for all the PFAS, like the class of over 10,000 chemicals, are also very limited. So we still have a long journey to go to understand those persistent organic pollutants. Thank you for the question.
Thanks. And there's a question somewhat along those same lines. Do you know of similar studies that are being conducted, particularly in Asian countries?
Yeah, of course. Yeah, like environmental chemicals are one of the main health issues in Asian countries. So there are also many other cohort studies that focus on prenatal or childhood exposures to PFAS. To my knowledge, I know there are many cohort studies focused on this topic, at least in China. But I don't know. I don't know well about other countries. Probably I can do a literature review later after this talk. But yeah, I do think for Asian countries, it's also it's also an important topic to explore. And as I said, PFAS are almost everyone around the world are exposed to PFAS, and they can accumulate in the food chain. It means the health problem is not a problem of one country or a subgroup of humans. It's a problem of it's a global health problem and deserve more attention. Thank you.
Thanks. And the last question here in the chat is whether maternal folate intake was related to serum folate, and are the current dietary recommendations for folate in pregnancy adequate?
Yeah, so in this study, our maternal folate is the folate is the maternal plasma folate level. So the modifier we use in this study is not maternal folate intake, but maternal plasma folate level. So it's kind of the internal level. It represents kind of the cumulative folate level from all the sources. And in this, like the WHO or CDC, they have recommendations for maternal plasma or blood folate levels. But in our studies, like, I wonder if I have that. I think I don't have that. But like in our studies, about 90% of mothers, their folate level is above the recommendation threshold of, not the is above the definition of folate deficiency. It means like based on WHO or CDC standards, those mothers are not folate deficient. But however, we still observe such effects like the like those inverse associations in quartile 1, which means like 25% of our mothers. And we, in quartile 2 to 4, we observed that the associations were attenuated. Like all of these mothers, their folate level are much higher than the than the standard level of folate deficiency. And those folate can protect the effects of prenatal PFAS exposure on mitochondrial DNA copy number. So our study suggested that the adequate folate level, which means way higher than the definition of folate deficiency, may have additional protective effects. So our current definition or recommendation for about like folate deficiency may be too low, or like we could recommend like higher folate intake or supplementations for pregnant women, especially for those who have higher environmental exposures. But all of those are based on solely our study, because this study is the first study that explores the modifying role of maternal folate. So
Great.
our study's finding still requires confirmation of other studies.
Great. Thanks so much. Great job again, Zeyu. Thanks a lot. So far today, we've done sort of a deep dive into Boston birth cohort study data. So thanks to our first 3 presenters. Now, I think we're going to shift gears a little bit. Our last presentation is from Shelby Rohlff, who has a Bachelor of Journalism in Advertising and Public Relations, and also a major in psychology from the University of Nebraska-Lincoln. Shelby is in the women's sexual and reproductive health area of interest. And Shelby, I'll turn it over to you.
Great. Thank you, Sally. Yeah, we are going to shift gears a little bit. So today I will be presenting my master's essay, which is titled Understanding Clinicians' Perspectives on Barriers and Facilitators Affecting Sexual and Reproductive Healthcare for Male Adolescents. Thank you to Annie, who is my reader, and also Arik, who is the PI on the Healthy You study, which this data comes from, and provided a lot of guidance as well. So there we go. I will start with just a brief background and the objectives of this study before going into the methods, walking through the results, and then we'll end with a brief discussion. So despite there being guidance around recommended sexual health care or SRH care for male adolescents, their receipt of SRH care is inadequate. We know that males are having sex as teens, and that they are disproportionately more likely than girls to have their sexual debut at an early age. And we know that adolescents have higher rates of STIs compared to adults. So it is very necessary that male adolescents are receiving sexual health care in order to promote positive behaviors and positive health outcomes. Current research on this has focused on males' perspectives of barriers to care, such as access, or clinicians' provision of SRH care to adolescents more generally, but there's little research that focuses on SRH care provision to male adolescents specifically. So 2 key objectives for our mixed method study. First, we wanted to assess clinicians' SRH care delivery practices and the confidence that they have in providing that care to male adolescents. And then second, we wanted to further explore what factors affect the provision of that care to male adolescents. So this study was part of a larger IRB-approved formative study that focused on designing a mobile app to support male adolescent SRH care. Clinicians were recruited through professional listservs, existing professional contacts, and referrals, and they were eligible to take part in our study if they had an advanced practice degree, such as being a medical doctor or a nurse practitioner, if they worked in a primary care setting, and if their patient caseload was at least 10% male patients in a typical week. And we had 12 total clinicians take part. All clinicians completed a brief survey regarding their current SRH care delivery and their confidence in providing that care to sexually active male adolescent patients. And we looked at 5 overarching areas. So that's SRH topics that they ask about, SRH exams they implement, SRH screening tests that they administer, SRH education and counseling, and SRH materials provided to patients, so things like handing out condoms. Clinicians were then interviewed to further explore their typical SRH care delivery, as well as factors that affect that care provision. For analysis of the survey, we pulled descriptive statistics using Stata, and for the qualitative work, we conducted thematic analysis and using inductive and deductive coding to identify themes. So moving to results. The results from our, the majority of our participants were women. They were white and nurse practitioners. They represented a wide range of specialties, which includes pediatrics, family medicine, adolescent medicine, internal medicine, and a wide range of clinical settings as well, as you can see at the bottom. The majority of the clinicians that we spoke with had 11 or more years of practice experience. Results from their brief survey showed that clinicians reported high confidence in SRH care on average. So you can see at the bottom an 8.3 on a scale of 0 to 10. They reported feeling very confident in specific things such as counseling on condom use, managing STIs, and items with lowest confidence included things like asking about and managing sexual dysfunction and infertility, but overall reported high confidence. Despite that high confidence, clinicians reported providing only about half of the recommended SRH care items. So you can see at the bottom, 20 out of about 38. On average, clinicians reported asking about 9 out of 16 SRH topics, conducting 2 of the 6 exam components, administering 3 of 4 care tests, counseling on 4 of 8 topics, and providing only 1 of 4 materials during a typical visit with sexually active male adolescents. Our qualitative interviews allowed us to learn a lot about the factors that affect the provision of care and may contribute to some of that low provision that we saw in the previous slide. Factors affecting SRH care to male adolescents were identified across 4 levels: patient, clinician, clinic, and systems. At the patient level, 2 factors affecting care are patients' comfort and willingness to discuss SRH care and patients' competing needs. So patients' comfort and willingness to discuss, clinicians shared things such as patients feeling hesitant to proactively discuss SRH concerns during their visits, whereas patients' competing needs refers to things such as other medical conditions, language barriers, other things that need to be balanced as we think about providing care. So the quote on the right really exemplifies this intersecting needs and patients' competing needs. They said, "In our clinic, we see a very high needs population. It's really hard to not get sucked into they're homeless, depressed, suicidal. They have many complex medical needs. Their asthma is poorly controlled. It's hard to not rush through the sexual health. I'm not going to have time to dive into all this stuff because we're going to talk about your asthma plan now." At the clinician level, clinicians discussed assumptions about SRH needs for male adolescents, such as what topics they felt were more or less relevant for their male adolescent patients, their standard of care for visits, which very much varies from clinician to clinician, and a lack of knowledge, comfort, and confidence related to some SRH topics, such as sexual dysfunction, or the appropriate language to use when working with sexual and gender minority individuals. And it's really important to note that there's a lot of interrelatedness between these 3 factors at the clinician level, as I will illustrate with this quote. So this doctor said, "I have bias maybe, sexual function problems. I've never thought about asking that because I didn't even realize it was a teenage problem. If they said they were having sexual function problems, I would do my best to address them, but it would be an awkward conversation. I've never had a conversation like that with a patient." So again, very much interrelatedness between these 3 themes here. At the clinic level, we see that resources, varying procedures and limited time for visits and physical environment constraints can all affect SRH care provision to male adolescents. Resources includes both staffing resources, such as the availability of health educators, and material resources, such as having condoms and lube to provide to patients. Procedural factors includes the lack of screeners specific to SRH care, and also the limited time allotted in visits to be able to discuss SRH care with patients. And finally, the physical space and how the clinic is laid out can make confidentiality and comfort discussing SRH more difficult. So I'll start with a quote that demonstrates how resources can affect care. This nurse practitioner says, "I don't always demonstrate with condoms. We had a health educator that used to run Condom Club, and before they would just give out condoms to anyone, they would say, okay, anyone can have condoms, but you have to demonstrate one proper use, and they put it on a dummy. And I thought it was amazing when we had the extra staff to do that." Another quote that exemplifies physical environment constraints. This doctor says, "Obviously, if the parent is in the room, the SRH conversation is never going to happen. And if it's like, okay, parent, can you wait out here right behind the door? Then it's not going to happen. But if we actually have a space for the parents to be where I know they can't hear us, then there's a higher chance." And finally, at the systems level, we see that restrictive laws and regulations, as well as a lack of medical education and guidance around male adolescent sexual health, can affect the care that male adolescents receive. Laws and policies at the state level can affect clinics' abilities to provide condoms, such as if they're at school-based health centers, and can also affect the ability to provide confidential care to minors. Additionally, medical education and guidance, as we saw a bit in our clinician level factors, really affect the clinician's ability to provide male adolescent specific healthcare. And this quote kind of demonstrates that there might be some gaps in that medical education and guidance. They said, "I feel like my education with adolescent health was not where I wanted it to be. It felt pretty generic in terms of development, and I would like to see something more nuanced. I would like to see more adolescent-specific education. I just want to be a better provider to my adolescents, and I don't feel like I found a lot of things." So, despite clinicians feeling very confident about providing SRH care to male adolescents, we see that they experience a number of factors which affect their ability to actually provide that care. And many of these factors are interrelated across the 4 levels of patient, clinician, clinic, and systems. To briefly touch on a few strengths and limitations, so we did have a small sample size, as I mentioned, of 12 clinicians, which does limit our generalizability, although they did represent a wide range of specialties and clinic types, which provides us with a wide range of perspectives. There is also potential for social desirability bias that may have affected clinicians' responses to both the brief survey and our conversations with them in interviews. Looking ahead, despite the small sample, the findings from the study do demonstrate the current state of male adolescent sexual and reproductive health care, and it's clear that we have some work to do. Many of the solutions to these problems operate at these more distal levels and are often interrelated. So, for example, at the clinic level, clinics can look to expand their staff resources, such as including health educators who may be able to help provide some of that SRH care and counseling that clinicians may not always have time for. Clinics can also consider updating procedures, such as allowing more time for visits to ensure that care can be covered, and ensuring the use of screening tools that may help support SRH care provision. At the systems level, there's a clear need to expand medical education and guidance to include male adolescent sexual and reproductive health care specific guidance. Funding mechanisms to support SRH care can also help to promote care delivery, and they can allow clinics to do things such as expanding staff resources and some of those other optimizations. So you can see these opportunities are very interrelated as well. Overall, there's a lot of opportunities to increase male adolescent sexual and reproductive health care provision, and we hope that this study sheds some light on that. So thank you all, and special thanks to Arik, Annie, Kathleen, Sophia, and Mo, who are on the Health EU team. And thank you to my family and to my partner, Elliot, as well. Thank you.
Great job, Shelby. Thanks a lot. So if people are, I realize it's close to 1 o'clock. If people are able to stick around, we'll spend a few more minutes together with Q&A. So I'll open it up, see if anybody has any questions. I see a question in the chat. Do you think the results or findings of the study would have been different significantly if the study included more male clinicians rather than female clinicians?
Yeah, that's a great question, and certainly something that we would hope to, do more research with in the future. I will say that the breakdown of our sample being predominantly women, predominantly white, does reflect the current pediatric nurse practitioner landscape. And so that, I mean, it is a fair, it reflects the current state of things. But yes, looking forward, I think we would love to see more research done with male clinicians as well.
Thanks. Other questions? Maybe I'll ask, like, is there one specific, if you could only recommend one thing based on your findings? I know you presented a few different recommendations, but is there something that you gravitate toward or that you think would be most feasible?
Yeah, I mean, I think that the idea of optimizing medical education and guidance, specifically for male adolescent sexual health care, is really important. A lot of people we talk to, like didn't think that certain things were applicable to young males, or were trained so long ago that they're like, we never talked about that back then. So ensuring that we are kind of keeping everyone up to date on male health, and art could speak much more to this, but I think male health education is kind of lacking in a lot of programs. So certainly that's an area for opportunity. And then just a plug for our team's work too. This is all part of work that supports a digital in-clinic health tool. So technological interventions are also a good way forward.
Thanks. Last call for questions. All right, well, if not, thanks everybody again for being here. Huge congratulations to our 4 presenters on really incredible work. We are super proud of you in the department. Thanks to all of the family, friends, advisors, essay readers for all the work that you did to support our students as well. And we're wishing everybody all the best and looking forward to celebrating more at the graduation party and also to another round of presentations, same time, same place next week. So thanks everybody.